So, Dr. Girish, when you say reconstruction surgery of the face, what does that mean? Who needs this and what happens?
Reconstruction mostly today is following either cancer surgery, where we would have done ablative surgery. That means the jaw has been removed or half the tongue has been removed, or many times half the face has been removed. That is one area. The second area is India was ravaged with post-COVID, during the second wave of COVID, mucormycosis was a deadly disease which came in. I mean, I don't think anywhere in the world in the COVID pandemic this was there. There was an endemic of mucormycosis. Mucormycosis is a fungal infection. So many times with infections, these are nasty infections where the whole jaw becomes necrotic, the jaw, or sometimes even going into the eye. And the disease was so bad that if it went into the brain, then we couldn't even save them. So this was another area where reconstruction has been, very, very commonly addressed by maxillofacial surgeons. The third area is post-trauma. When you have a very nasty accident, then parts of the face have been completely shattered. Could be the bone, the soft tissue. At that point of time also we are doing reconstructive surgery. So tumors, infections, and we are talking about trauma. These are three broad areas where we are talking on reconstructive facial surgery.
And of course, we know that this has been going on for a long time. Maybe some primitive techniques and things like that. So what has changed in the recent years?
Reconstructive surgery, if you really look at it, I think India was a leader. If we look at Sage Sushruta, who is the father of surgery, he actually described reconstructive surgery for the nose. Good old days in India for adultery. One of the punishments was chopping off the nose and ears, right? And it's also there in our epic Ramayana. Lakshmana taking off the knife and basically chopping off the nose and ears. So that was a big of Shurpaniki. So that was basically a big taboo. And for that, India was so advanced at that point of time. And Sushruta has described this technique of reconstruction of the nose, where he has taken a bit of skin along with its blood supply. We're talking of the supraorbital and supratrochlear vessels, and rotated the forehead and closed this primarily and reconstructed the nose. This was seen by some British doctors when India was ruled by British in the 17th century, right? And that was actually presented in UK in one of the journals. And people came to watch this Kawasaki's technique, which Sushruta had mentioned of reconstruction. So if we talk about reconstruction, it actually started in India, reconstructive surgery. And then during the World War, the Second World War, I would say, or First World War itself, when there was so much of, the fights which happened on the trenches, that is where the faces were blown out. And, reconstruction of the face started, the modern era of reconstruction. And Harold Gillis was a plastic surgeon. Within me, I had a couple of oral surgeons. At that time, it was not maxillofacial surgeons. Killy, Kay, and, different surgeons who basically went in and reconstructed the face, including teeth and jaws and the whole facial parts, taking tissues from other parts of the body and molding it and putting it here. And that's how the whole speciality, you could mold tissues, we could plasticize them. And that's why plastic and reconstructive surgery started. And along with that started another branch from dentistry is maxillofacial surgery. So we work very closely together and we do reconstruction of the face.
Nice. So where are we today? What can we achieve?
When it comes down to reconstruction today, when we are talking on oral cancer or in mucormycosis or in trauma, today we are doing cutting edge reconstructive work. And we believe that a part of the tissue, if it has to be replaced, like tissue has to be replaced. So skin has to be by skin, muscle with muscle, and bone with bone. So we have something called as microvascular reconstruction today, where we take parts of the tissue, say a jaw has been removed, upper jaw or lower jaw. Today, the norm, I'm talking about almost all our patients get reconstructive surgery today because we believe in giving good quality of life. It's not just taking out the disease, but actually giving them dignity, giving them function, giving them that kind of hope that you can be normal. So bone from the leg is taken, that's the fibula. You have two bones in the leg, the tibia, which is the weight bearing, which don't touch, but then the fibula is the spare bone which you have. That we take along with its artery and vein and plumb it into the artery and vein in the neck. Similarly, we can take hip bone and put it across here. Muscle can be taken, it could be from the thigh or it could be from the hand, and you can give a soft tissue for the tongue, for the cheek. These are cutting edge reconstructive techniques which we are doing today. And this is a norm for the last 20-25 years we have been doing that.
It's hard to imagine, like when you say you take fibula or hip bone and things, and then to put it in the face. It's hard to imagine that it would conform to the facial features and things like that. So how do you manage to get that?
Yeah, I mean, this is very interesting question you asked, because the leg bone is a straight bone, right? And the jaw, many a times we have to take out the whole jaw or the upper jaw. Both are horseshoe shaped.
That's right.
So it is very, very important. This is very technique sensitive. So that straight bone has to be osteotomized. That means that we have to cut it into bits and give a shape of that. So along with that, you have to put a contoured plate, right? In the past, when we were training, and then in the earlier days, I'm talking about, last 15 years, it was a very big challenge, and that's where skill was the most important thing, right? So we would take models and try it out, what's the shape, and then get it. It was more with your experience, you could get good results, or if that bad day, it could get bad results in terms of shape. Today, technology has come in. We have something which is virtual surgical planning, right? We're using computer-based training. In the CT scan, you can actually plan. The leg bone, we know exactly where we can make our cuts. So you have cutting guides, which give us, like your GPS, it gives you guides to make our perfect cuts, and it can be so accurate that it's unbelievable. So technology, if it is used well, has to be adapted. According to me, you need to use technology that is to give better outcomes. And that is a revolution, I would say. So 3D printing, virtual surgical planning, these are game changers which are giving us very, very good outcomes in reconstruction.
Very nice. So that's the bone part of it. And the same thing you can do with the hip bone as well.
Yeah, both, either leg bone or hip bone, we can get it. But getting the soft tissue
that's where
is a big issue.
Where do you get this soft tissue from?
Soft tissue, the muscle and skin, we take it from the chest muscle, because it's just not taking tissue. You'll have to take it along with its blood supply and the vein. The pedicle is the most important thing. With microvascular transfer, you can detach and then detect to again plumb it again in the neck. So it becomes viable immediately. But when you're having a pedicle flap, you have the bulk of the flap and issues with that. So planning is the key. Ultimately, it is the training and planning which gives better outcomes.
And how often do you need to do this?
Oh, almost every day. Today, whenever we are doing ablative surgery, patients are very demanding because everybody wants to basically have a normal face. And when we are mutilating them by these kind of surgeries, taking out parts of it, it's very, very traumatic for the patients, because even a small scar when you have, people are apprehensive about it. They don't want to show their face. So when we are taking out a whole part of it, a jaw is taken out or a tongue is taken out, we are giving them reconstructive options. So it is done every day. Almost every center actually is doing reconstructive surgery today.
Very nice, very nice. And what's the commonest indication to do this?
Again, as I said, the most common is cancer. Cancer is probably the most, but mucormycosis was another thing which we have done, which we had never seen. I mean, I had probably seen about 4 or 5 mucors every year. I'm a busy surgeon, and even in my center, we used to see very rarely in immune compromised patients, very, very poorly controlled diabetics, or patients following chemotherapy or transplant, where they are on immune suppressant drugs in such cases. But with the COVID thing, we had huge, 25,000 cases in India we had, mucormycosis. That was an endemic, I would say. And for such kind of cases also reconstruction, but very nasty accident. Sometimes we have to take out the eye in a trauma, burst globe, or parts of the face is lost in such kind of cases, we are doing reconstructive following trauma too. So those are the absolute indications for that.
And how long does this take?
The surgeries are quite long. I mean, the surgeries could be anywhere from 8 to 15 hours sometimes. I mean, my longest surgery is probably 36 hours.
Can only imagine.
So it's 24 hours I've been involved in at least about 4 surgeries. So in my career of, so many years, so very long surgeries, yes. And but generally most of them would be about 8 to 10 hours.
8 to 10 hours. And how do they fare post-operatively?
Very well, actually. I mean, with our anesthetic colleagues, they really manage very well. And today it's very, very good. And I'm myself surprised when somebody has been through so much of surgery. When you see them in the evening recovered or awake and doing well, and the next day they are very, very well. So it's good.
What complication are you expecting or you explaining to the patients?
When we take up these kind of reconstructive surgeries, it's not just one surgery. Many times you have to do further surgeries. That is something, because the bulk of the tissues, sometimes we take into factor that these things shrink. Not the bone, we are talking about soft tissues. So many times we will have to do a repeated revision surgeries, that's number one. But sometimes the flap itself fails. There could be a problem with the blood supply or bleeding and things like that. So we may have to do another reconstructive surgery. So that is something which we have encountered, and we have to salvage these issues too.
And infection rates and things like that?
Infection, yes, sometimes you can get infection which can lead to dehiscence and breakdown of the flaps and things like that. But bigger problems is nutrition. Many a times these patients are very much compromised, so the healing doesn't happen at all. So sometimes these things fail because of lack of nutrition. Although we infuse a lot of nutrients into during the post-op phase, but still it's very challenging in very emaciated patients. Sometimes you can't do surgeries because they are not fit to undergo surgery. So medically compromised patients, it's a bigger challenge. Poorly controlled diabetics or immune compromised patients, these are tough.
How do you manage oral intake for this, especially facial reconstructions? That is
good
challenging, isn't
good.
it?
Yes. I mean, till the flaps take up, we have to have tube feeding, mainly a gastric, nasogastric tube. Sometimes we put a tube directly into the stomach when we know that it's going to be a longer period of time. But within the next 1 or 2 weeks, people are up and about going through oral feeds. But it is a challenge. And when we have taken out parts of the jaw, many a times they can't chew because it is only bone and soft tissue. And today that is the reason why we have been putting in dental implants and into the reconstructive bone. So there are times when I put in the leg itself these implants, and we transfer it across here and give a crown on top of that.
Okay, so they can even chew food with that.
Absolutely. We have a procedure called as join a day. That's something which is a game changer, I would say. So if somebody has got cancer of the jaw, be it upper jaw or lower jaw, we resect it. That means that we are taking out the whole of the jaw or half of the jaw. And reconstruction is done taking bone from the leg or hip. Those are the most common one. Many times we also have a skin cover on top of that. So now this is only giving you a form, but you can't function with that. The biggest problem in function when you talk about the mouth is chewing and also speech. So these two get compromised. And if we are able to give teeth, your mastication, that is the chewing efficiency, comes back, and it is almost as good as what you had earlier. So that is a revolution, I would say, in the last, I would say 20 years. 2003, 2004, when I was probably one of the first guys in the country to put in implants in the leg, transfer it across here, and give teeth also on the same day. That is join a day, right? So 2003, 2004, when we started in Bangalore, and that today I'm glad that a lot of centers across the country are doing that cutting edge work. So we have trained a lot of youngsters to take up implantology. So it's not just reconstruction, but also rehabilitating them with teeth. So that is very, very important. In addition to that, into the cheekbone, sometimes we put implants. These are long implants. So instead of taking bone from the leg, we put into the cheekbone, that's zygoma implants. So we just give a soft tissue cover on the palate and put 2 implants across here, or sometimes 4 when we have taken out the entire upper jaw. And that is something which is revolutionizing. Today, you also have 3D printing technology. We have something called as patient-specific implants. That means that we custom-made it to you. So we do virtual surgical planning. Everything is done on the computer, and we print these prostheses with titanium or PEEK. And to that we can actually fix teeth. You give a cover of the soft tissue and you're able to do that. Especially for mucormycosis and for a lot of cancer cases, we have done this and very, very successful. So join a day is a very, very nice concept today, which we are doing it here.
That's nice. Is it done all over the country?
Not everybody does that, but there are a lot of centers which have now started doing
Picking
it.
up.
So yes, I'm glad that a lot of youngsters are passionate about it and they are coming in and training, and then they're undergoing this kind of cutting edge work which they're doing.
And these dental implants what you put, so they're all synthetic teeth.
Yeah, I mean the implant is the bit which goes into the bone, so that is made of titanium. Titanium is a very biocompatible material. So if you put, whenever a tooth is taken out today, the accepted treatment is basically putting a dental implant. And I started very, very early. 99 when I came back, I started doing it. 25 years I've been practicing, probably done more than 30,000 implants, one of the highest in this part of the world, I would say. And it's very rewarding because you can very predictably, as long as you choose the case right, you are able to go in and place the implant in. And that was an extension for reconstruction. So being a surgeon, I took it to the leg and, going into the cheekbone. And in fact, we do it when an eye has been taken out or when an ear is missing. I put the same implants into the temporal bone here and put a prosthesis directly fixed to that, or into the eye when we are replacing it with an artificial or a prosthetic eye, what we call as. I put implants around the orbit, that's the eye socket, and to that we fix it with magnets. It goes in and latches on. So you don't have the fear of this thing falling off, and that is something which we have done a lot in our center.
That's nice. So these are the hard bits of implants what you're talking
Exactly.
about. What about tongue reconstruction? How do you reconstruct tongue? Is it functional?
Yeah, I mean, once we have taken out the muscle and the nerve, the same bit which we are putting in, like we take from the skin, from the hand, radial forearm flap we call, or sometimes from the thigh or from the chest muscle, it's only a soft tissue bulk which we are putting in there. So half the tongue when we have taken out, this is giving that kind of thing. Sometimes we don't even do the reconstruction of the tongue because half of it's there. That itself actually grows. The muscle hypertrophies and becomes like the tongue. But when there are clear indications where we have to do reconstruction of the tongue, that doesn't have taste because the taste buds are all gone. So you don't get any taste on that side. But definitely it helps in speech. That is something which is there. Movement also to some extent, yes. The other tongue actually, other side of the tongue takes it through. So it's more of a bulk than a functional issue there.
Swallowing? Is there any problem?
Swallowing is not a problem because the posterior 1/3 of the tongue, which is generally left, if you've done a total glossectomy, that means that the whole of the tongue is taken out, then it's a nightmare. So there is no movement in the sense like you have to basically train people to swallow, or sometimes we just give them a feeding tube directly into the stomach. So that is where it is. Very advanced disease. That's a nightmare actually. So bone is good in terms of easier, in terms of getting better outcomes, but when it comes down to soft tissue, function wise it is a challenge. And that is where we need to do more research, do more evolving of science, which can ultimately, maybe with today, the way in which you can grow tissues outside, that might be the way forward. Tissue culture and things like that is something which probably in the next generation or next few years, hopefully, we will see that revolution happening.
Are we doing something like that in the country towards that?
Yeah, I mean, there are good centers in India where we are working on regeneration of body parts, and we have been doing that. So yes, bone cells, soft tissue cells, but it's still a long way to go, I would say.
So as of now, we have to settle for
tissue transfer from different,
autologous,
or patient-specific implants where we have 3D printing. So we are looking at building in scaffolds. That's another area which we are working on. So bioresorbable scaffolds, which we can actually do, in which you can put cells in. So you can put bone cells in, you can put cartilage cells in, you can put muscle cells in, you can put skin cells in. But getting that layering right is very, very challenging. So we are still in the lab work stage, but I think it's not too far when somebody, you never know, one youngster would just come up with this kind of thing, and that would be a game changer in reconstruction.
Very nice. Again, how affordable are these things? And how accessible are these things to the general public?
Yeah, as I said earlier also, affordability is a problem. But as in India, you have a mixture of everything from government institutions which are doing some great work to charitable organizations to corporate hospitals. So we somehow find ways in which we can actually do it. Compared to the West, I would say it is probably 1/10 the cost here. So even in the corporate hospital, it's very, very reasonable. So insurance sector is also playing a major role today, and they're covering reconstruction also, including dental implants today on rehabilitation. So that is very good. A country like Scandinavia, where implants are given by the insurance, not an issue at all. But in most of the other countries, we are struggling. But it's changing. I think, everybody is looking at quality of life, and people are spending. But there are organizations which are coming in, philanthropists are coming in, and they are helping in improving quality of life. So it is definitely happening today.
As you said, nobody is denied of this.
Absolutely, and this is something which we have seen. People do get the best treatment, be it in a government institution or a corporate or a charitable hospital, and we are there to help people. So a lot of organizations are funding it today.
Nice.